ladies. Hey, Share. Okay, we'll just wait a minute or two for more people to come in, and then we will start our little chat today. Hello, thanks for joining us. Okay, so ladies, before we start on today's chat of PGD and PGT, PGD and PGS testing in Singapore, okay, we hope to make a disclaimer that although in our talk today, okay, medical advice is given by the actual doctors. However, everyone's situation is unique. Therefore, please get the advice of your own doctor before you proceed with anything at all. Okay, so today's topic is PGD and PGS testing in Singapore. So we have invited Dr. Roland Chieng and Dr. Liow Swee Lian from Fertility Center. Okay, we're very happy to have them, so let me invite them in right now. Okay. Okay, give me 1 minute. So let me just invite them in.
Hello.
Hi, Dr. Chieng. Okay, Dr. Chieng, I'm just going to invite Dr. Liao in, and then we can start our chat. Okay, let me just contact. Right. Got it. Okay, so just waiting for Dr. Liao to come in. We've got a lot of your fans here today, Dr. Chieng. They have messaged us. Okay. Dr. Liao, come. So you can see all the ladies saying hello to you. They must be your patients. Okay, hold on.
Hi, everybody. Hi. Where is Dr. Liang? Still having dinner?
I don't know. Okay, hold on. Have you had your dinner?
Yep.
That's good. All right, okay. So sorry, guys. Some technical error. So sorry. Okay, let me just quickly call. Okay, hold on.
Do we have an airtime limit?
No, we don't. 4 hours. 4 hours.
4 hours.
So we were a bit worried last week after we ran past the 1 hour because it used to be 1 hour, but they changed it to 4 hours this year.
Okay.
Okay. Let me see. Okay, wait. Let me just try this.
Hi.
Hello, Dr. Liow.
Hi.
Hi,
Good evening. Hi, Roland.
Okay, all right. Thank you so much for joining us today. Okay, so today's topic, PGD and PGS testing in Singapore. Okay, before we get into the topic, maybe we could start with an introduction from both of you.
Maybe Dr. Roland first.
Yeah. Okay, I'm Roland Chieng. I'm very happy to be here. Good evening to all of you today. I'm currently medical director of Fertility Singapore, and I'm an IVF physician, and I've been doing IVF for the last 20 years now. So very happy to be here because in fact, since Verta started more than 5 years now, we are running into our 6th year, and with Dr. Liow on board, and we are very happy that we are doing okay. We are very happy with what we have done. Dr.
That's
Liow?
great.
Hi. Good evening. I'm Dr. Lian here. I'm the scientific director of Fertility Center Singapore. I'm looking after the little babies and helping couples to achieve a good outcome to start a family. And I've been in this field for 30 years now.
Wow. Okay, so as all of you know, we have two very experienced doctors on board today giving us advice. Okay, so let's go straight into the topic. Okay, so I think the biggest questions that everybody has is, what is the difference between PGD, PGT, PGS testing? Yeah.
All right. Let me answer that question. Now, of course, there's a bit of confusion here among the public regarding PGD or PGS. Now, these are acronyms. Now, just to define them, PGD means pre-implantation genetic diagnosis, and PGS means pre-implantation screening. Now, what happens is that the procedures that is done to get a biopsy of the cells of the embryos and then send it for genetic testing. Now, for PGD, pre-implantation genetic diagnosis, is more for looking into areas of gene mutations or some chromosomal abnormalities like translocations. Whereas for PGS, it's just a screening of the embryos just to make sure that you have the normal number of chromosomes. For us humans have 46 chromosomes. A chromosome is a housing for all the genes that is a blueprint for us. Yeah. So anything that goes beyond 46, that means it's abnormal. So that is PGS. Okay. But currently the latest acronym is known as PGT, which means PG pre-implantation genetic testing. And it has been broken into three definitions. PGTA means PGT aneuploidy. A for aneuploidy means a normal number of chromosomes present in the embryo. PGTM means looking at the gene mutations, specific gene mutations that are present in the embryo that can transmit from generations to generations. In PGTSR, you're looking at some abnormalities in the chromosomes, just like the translocation that can affect fertility potential of the offspring.
Okay, so let's say if somebody has genetic abnormalities, which test should they actually do?
It depends on, of course, the screening. The couple have to go for a screen. Just like, let's say, if both of them have a carrier for thalassemia, which is a gene mutation. So the testing will be PGTM. But it is if one of the partners have some abnormalities in the chromosome, like translocation. Translocation means a certain portion of the chromosome, let's say number 14, is attached to another chromosome, number 21. That causes some infertility problem, and that which can be tested for embryos that have a normal, balanced translocation, normal ploidy. Yeah.
Okay. So let's say, would you suggest for everybody to go do testing, or who do you think should get this testing done?
I would not suggest everybody to go for testing unless they have specific genetic disorder in that sense, like what I just mentioned, like thalassemia or chromosome translocation.
Okay. So, but let's say if there's a couple, okay, they've done IVF a few times, they've failed transfers a few times, or they've managed to get pregnant, but they constantly have miscarriages. Would you suggest for them to do the testing?
I think Dr. Roland should answer that. Yeah.
Okay. In this case, you have two scenarios. One is when couples have failed repeated frozen embryo transfer. Now, generally, when we look at failed embryo transfers, we will shift our focus on how to maybe looking at the embryo factor, and then we'll see whether there is any issues about the egg quality, the sperm quality, with the main aim of achieving better and better embryos. So in that case, we're hoping that the implantation will become better. Now, so therefore, when you have repeated embryo transfer failures, generally, I think it's not the time to look at testing. However, if you look at on the side of miscarriages, let's say you have repeatedly failed pregnancy, then in that case, again, of course, the embryo factors as what we mentioned for the frozen embryo transfer is the same. So assessment again will be going into improving the egg quality, sperm quality. However, in this situation, there might be a place for pre-implantation genetic screening, which is as what Dr. Liow mentioned about PGT-A, checking for aneuploidy. Now, in that case, the main reason again of doing that is especially for couples who have gone through repeated miscarriages. So the main aim, in fact, is really just to find the right order of transferring our embryos, such that we are able to minimize the chances of miscarriages.
Understand. Okay.
Yeah.
Understand. All right. So, okay, we know that for a lady who has decided, let's say, okay, a couple have come, they decided, okay, we need to get the testing done. Does Virtus have a lab to run this testing?
Well, currently what happens is that, in Singapore, there's only one recognized laboratory that is allowed to perform the genetic testing of the biopsy of the embryos that is located in the NUH called PGT lab. Now, recently there have been some guidelines issued by MOH now that allows the fertility centers, the private one, to participate. And there's a possibility that we have registered our interest in setting up the PGT lab in the future.
I see. Okay, so not yet at the moment. Then.
Not yet.
Okay, so Singapore, Singapore is such a medically advanced country. Why is it taking so long to embrace testing in Singapore?
Well, I think first of all, I would like to just to clarify. I think recently we announced about this service of PGD being extended, being licensed. So I think it's time to clarify to the public that we are still looking at pre-implantation genetic diagnosis of PGT-M and PGT-SR.
Okay.
Whereby it is important to realize that we are looking at a specific abnormality that has been diagnosed, and whatever that you are aiming to do is really to do a testing to exclude a specific abnormalities. Now, as for PGS, which is the new term is a PGT-A, it is still not allowed, because in this case it is really down to looking for down to finding a better embryos, the best quality embryos. So that is still not allowed. So I think there is a lot of misconceptions thinking that,
Yeah.
okay, now it is finally we are able to do pre-implantation genetic screening.
Correct.
Now, if you look at Singapore situations, I don't think we are, in that aspect, we are not slow because, in fact, if you look at PGD, there's a diagnosis of a certain known genetic conditions.
Yeah.
It has been around for the last 20 years or even more.
Okay.
Yeah. Yeah, and the only thing that is not available at the moment is, as I said earlier, is about this pre-implantation genetic screening, whereby we are screening out the abnormal embryos to transfer without any known condition.
Understand.
Yeah, that is
So
still
basically,
not there.
in a nutshell, there's a couple, they have no problems. Basically, they shouldn't, unless there's certain problems, then they should go for screening.
Exactly, yes.
Understand. So, okay, so let's say a couple has gone through embryos, has done the testing, okay? They have successfully implanted it and have got pregnant, okay? Can they skip all the tests further on? Like, for example, the panorama test, the Hami test, Oscar test, which basically tests for abnormalities, Down syndrome, and this and that. Can they skip all those tests?
Right. So if you're talking about PGS, which is a screening for the embryos that has been transferred, tested embryos that have been transferred. So at the current moment, we are still recommending, because most of the time I have to clarify again, I will be assuming that these are the embryos that have been transferred overseas. So it will not be in Singapore because it's still not allowed in Singapore yet. So if that's the case, generally we still say that the routine of pregnancy follow-up is still necessary.
Okay.
Yeah, because
so still go for your test, basically.
correct.
Don't skip them.
You can't afford to skip them because as I think one of the main issues about pre-implantation genetic testing for aneuploidy is that it is rather controversial still. And we always maintain that it is going to be quite difficult to have a single biopsy of the embryo to assume that the biopsy is representative of the entire embryo.
Understand.
Yeah.
Okay. All right. Makes sense. So let's say if there's only a lady who has very few embryos, okay, but she has been recommended for testing, is it still worth doing?
Well, without any known diagnosis or known conditions to avoid, again, if we discuss about pre-implantation genetic screening, again, I think one of the things that we stress so far is that despite going through screening, you are basically screening on what is available.
Okay.
Okay, so therefore, this screening process does not give you better embryos. So if you have very few embryos, we are in view of the controversial testing and all that, I would recommend that you probably better off just go ahead and transfer.
Yeah. Okay. Yeah. I agree. All right. Okay. So some scenario-based questions for someone who basically is doing PGTM. Okay. It's a numbers game. They need a lot of blasts. Okay. Do you have any secret method or anything that helps them increase the number of blasts that they get?
Well, I think it's all up there. Our primary objective of embryos in the lab is really boils down to how to optimize egg quality, sperm quality in order to get a good embryos.
Yes.
So you might have gone through the testing and all that whereby there are probably no normal embryos to transfer. I think one of the things is really just to get more embryos, and hopefully with improvement on the egg quality and sperm quality, you can get the number that you need, rather the normal embryos that is worth transferring.
May I add also that sometimes now, of course, sperm and egg quality is very important, but also the ability to choose the right sperm to get in to improve the outcome of the blastocyst yield, as well as like what Dr. Roland say, if the patient one cycle have very few blastocysts, maybe 1 or 2 blastocysts, it's not economical for it to do it, but maybe perhaps if depending on the whether the couples can go further for 1 or 2 more cycles to accumulate, call it embryo banking, then perhaps maybe hope to get more blastocysts, then you can send it for diagnosis.
I see.
So in that, sorry, Kim, I just in that aspect, it boils down to as much as possible we need to optimize again the egg and sperm so that we can get our blastocysts. Because,
Understood.
you know, unlike the old days whereby we could, you know, they are, you know, doing biopsy on the cleavage stage embryo, that means day 3 embryos.
Day 3.
Now I think it's standard practice that we need to reach blastocysts, but we all know that in order for embryos to progress from day 3 to day 5 of blastocysts, it's not an easy task.
No, it's not.
Yes.
Okay. All right. So just for reference sake, okay. So let's say if somebody wants to send their embryos for testing, what is an average number that you would say? Okay, you have 5 embryos. Let's send it for testing. Or what would you say?
Now, first of all, sending the embryos overseas for testing, of course, we try not to encourage that because it carries a lot of risk in the sense that, you know, you may during the transport process of the shipment from one center to another, there may be a risk of damaging the embryos or loss of embryos. So you need to get a qualified courier, preferably by, you know, personally come and collect and then transfer from one center to another center within a reasonable time period. And now, of course, you were saying embryos tested. Well, we try not to encourage it, but if it's, yeah, that's all we try to say. But again, those embryos that have been tested and found to be normal, so-called normal in the overseas center, the MOH doesn't really encourage them to come back for transfer. So the patients are required to go overseas to do the transfer. Yeah.
Yes. So we actually do have so many ladies who actually message us and ask us, you know, oh, all my embryos are overseas. What do I do? Honestly, we don't know either. So yeah, so that's the thing. So okay, just on the side, if we have like a 4AA embryo, is that 4AA embryo gonna give, like, will it, when it's PGT tested, would it be a good testing, or you know what I mean?
Yeah, 4AA means it's an excellent embryo, but then again, the grading is very subjective because most of the grading is individual. You know, one embryologist may grade as 4AA, the other grades as 4AB or something else. So now, of course, if you look at it objectively, let's say you grade as 4AA, so there's a good potential that this embryo has at least 70% chance of implanting. That's all. But it doesn't really guarantee that you result in a live birth. Yeah. But of course, the live birth rate, chance to get a live birth will be higher, but it doesn't really guarantee that. Because there may be some other, probably some genetic abnormalities with chromosome numbers that are hidden in there, which you cannot detect. Yeah.
I see. Interesting. Okay. All right. So let's say for a person, okay, normal AMH, okay, is there anything to look out for when they are doing stims for the first time? They're going to send their embryos for testing, okay? Is there anything that they should look out for?
Well, I don't think it is going to be any different. So again, the usual pre-IVF testing and assessment, down to what type of regimen is the best for you and the dosage. Yeah, so all that will be quite the same.
Okay.
But you know, whether you have a higher dose or lower dose that will change the embryo, this 8 number, I certainly don't think so. Basically, what you're looking at is really to have the most effective therapeutic, or rather the effective range of medication in you in order to respond optimally. So therefore, even if you have more of a certain medication, it doesn't mean that you'll respond better.
Okay, so that means it doesn't mean higher dose is better.
That's right. Yes.
Okay. All right. So we don't be kiasu and just ask for more medication.
Well, I think
okay.
I think from the physician, from the doctor's point of view, I mean, a lot of the time, what we want to do is to achieve the desirable result with the lowest amount of medication.
Understand.
May I add also in there is that yes, overall the number of eggs collected is important, but to me, the egg number is not the most important thing. Most important is the quality. So with the optimal amount of those stimulation, the drugs for stimulating eggs, that will be the better choice rather than using excessive hormones to get just number of eggs.
Agree.
Understand. Okay, so let's say there's a lady, okay, they do not have, so let's say they've done one round of IVF, okay, not enough blast to do testing. Would you recommend a back-to-back where, so just to explain back-to-back to the ladies, so where we do one set of stims, get a egg retrieval, and then straight away the next month we go back into stims again. Would you recommend that?
Yep. Currently, I think back-to-back stimulation is not an issue. In fact, I think there are some evidence to show that back-to-back stimulation, you could actually produce more eggs or being more responsive. But generally, I think one time back-to-back, that's what I'll recommend. But beyond that, generally, I'll advise patients to have at least one cycle in between before you start on another cycle.
Okay.
But I think this type of stimulation cycle is really quite limiting in Singapore because the cost is a primary concern.
Yes.
Whether you're going to pick up 10 eggs or 1 egg, the cost unfortunately will be the same.
Yes.
Yeah.
Correct. Understand. Have you heard of one where basically so it's not, I don't think it's specifically back to back, but after you do the egg retrieval, instead of waiting for a cycle to start, straight away you go back on stims to grow it again.
That's right.
Yeah. Do you do that in your center?
Not for me.
Okay.
But it has been shown that is what we call the dual stim method,
Yes.
dual
Correct.
stimulation
Yes.
method. Yeah, so basically what you are doing is that you are stimulating as usual in the follicular phase, and after the first egg collection, you go on and start stimulation in the luteal phase. Yeah. Now, I mean, from what I have experienced, I think this is just an opinion. I have not found it to be very useful, and
Okay.
I feel that back-to-back is with the current stimulation regime, because we are nearly I think very few people now do long cycles, so our treatment is really quite fast in terms of treatment stimulation leading onto egg collection.
Okay. Okay, good to know. All right, so when a patient, okay, let's say a patient, okay, their embryos have failed testing. They've done it a few times, always failed, okay? What is your advice as a next step? Would you suggest using donor eggs, donor sperms, which is quite controversial in certain ways, but would you recommend it?
I think with that scenario, we are back to what we talk about again. We in Virtus, I mean, me and Liow, we work very close together. And we have been talking about egg quality, sperm quality, how to optimize this and that all the time. So I think if you have failed testing, it all depends on the patient herself. If she's still, keen to carry on, I think we will continue to improve on that aspect. Now, when you talk about donor egg and donor sperm, it's really quite, easy way out. But of course, if let's say, if you can't carry on with any more egg collection, probably that would be the way to go.
May I add about, let's say if you talk about field testing, meaning that, let's say the outcome of the PGT of the embryos is non-transferable, it doesn't mean that the embryo cannot generate a pregnancy, because the embryo itself, when it does start from the first day to the 5th day to the blastocyst stage, it undergoes self-correction. So along the way, and then depending on the site of biopsy. So if that site happens to detect that, this embryo is non-detectable, non-transferable, doesn't mean that embryo cannot be transferred. Because because there are different, we have a few real scenarios whereby patients came up with a result saying that mosaic, we call it mosaicism, means there are more than one chromosomal constitution. We just put them in and healthy babies are born. And it has been documented in medical journals here too.
That is actually really interesting. So, I mean, so that means PGT testing may not be a fully unhealthy baby at the end of the day.
Correct. In fact, there's a recent paper in Nature that says that PGT is not beneficial. PGTA, not beneficial to most women, unless they have a genetic mutation or a chromosomal translocation.
Yeah. Okay.
So I think it's important to clarify that I think what we talk about by Dr. Liow is really on PGS, or what we talk about, PGT and euploidy. Yes. Yeah, because
Okay.
PGD, if you're talking about pre-implantation genetic test, this testing for this monogene and structural rearrangement, then it is a very specific diagnosis. So the story is
Yes.
different.
Yeah.
Understand. Okay, interesting. Okay, so now just to go, okay, so we've had a lot of ladies who also messaged us on general questions, okay, since you two are very known doctors, okay. So I think the biggest topic now and on everybody's mind is the vaccine, okay. So with the announcement of pregnant ladies being able to take the vaccine, what are your thoughts? Can we take the vaccine before egg retrieval, or let's say we've done egg retrieval, can we take the vaccine before transfer? Will it affect our embryos?
Well, I think we all understand that it is a trying period. I think from the time when this COVID-19 first started till now, we are looking at probably just about 1.5 years.
Yeah.
So I think in terms of whatever information that we have on the possible effect of the vaccine, in fact, what we know about vaccine is even shorter than that. I think we know about it probably just over a year. Now, I think very little, with such a limited information, there is really very little to refer back to. But generally, my advice is that if you can wait, then of course it is good to wait, including whether you want to go for egg collection or not. But if you feel that you can't wait, well, the current Ministry of Health has already said that with the current information, it appears to be quite safe. And in fact, they have been recommending that even pregnant mothers should have vaccination. So if that's the case, then I would say that it is, as long as you are informed, you should be able to go ahead. Yeah, the risk should not be too high at the moment.
So let's say after we take the vaccine, do we need to wait like a month or so, or should we just go can we straight away start our stims?
Well, I would say the usual recommendation for vaccine is still, give yourself after the second dose, maybe about 1 month of waiting. Make sure that you are well, you're healthy, and then we move on to start the stimulation.
Understand. Okay. All right. Okay. One question, just leading back to PGS testing just now. In what scenarios would you recommend embryo banking, whether related to testing or not testing, but under what scenarios should a lady say, okay, let's do embryo banking?
Dr. Roland, what do you say?
Embryo banking. Generally, I mean, this is a question nothing to do with the testing at the moment.
Yes.
But generally, I would say that age is probably the most important factor. So I usually advise patients to go for banking if, let's say, they are starting treatment after 40. So if that's the case, we know very well that with every year that pass by after 40, the chances of your egg quality to deteriorate is going to be drastic. Yeah. So I will say that maybe we should postpone our embryo replacement, and just focus on trying to get as many good embryos as possible.
Understand. Okay, good question. All right. Secondary infertility. We're seeing more and more ladies facing secondary infertility now. Is this normal? I mean, what are your thoughts?
Wow. Secondary infertility means, first of all, it's defined as trying to conceive after being pregnant. Yes. And you are unable to after 6 months or a year. So if that's the case, most of the time the assessment will be the same as as how we work out primary infertility. Okay. Now we all know very well that one of the main concern about secondary infertility is age factor, because a lot of our women, by the time they gotten pregnant and then completed their breastfeeding, they are just getting older. Correct. So that will be the main concern, because we know that with age, your chances of fertility continues to drop. Now, the other thing is, I always say that, previously you tend to work very much harder, because you got nothing more time, and probably there's nothing much to do. But now with something in between, it's not going to be so easy. So naturally, I think a lot of couples, when they come forward for such concern, they usually have very little sexual activities. So that could contribute just as much to secondary infertility.
Understand. Okay. Next question. Supplements. Okay. So a lot of doctors will say, "Oh, take your supplements." Okay. And so yeah, probably I take maybe about 20 pills a day just in supplements. So what is your recommendation? Are supplements important?
I must say that I'm overall quite conservative. So
Okay.
yeah, I do not I'm not so much on the side of the abundant supplements to make things better. But
Okay.
but I think the most important thing is that we have to be aware of whether supplements could potentially be harmful, especially on the
Okay.
source of the supplements, and also the preparation process of the supplements. So as long as the supplement is a reliable source and is not going to be harmful, so I think there should not be any issue.
Okay.
May I add also is
Yes.
that I think most important is to look after ourselves. Most important, health. Yeah. Have a proper balanced nutrition, exercise, sufficient rest, and so on and so forth. And
Yeah.
of course, because nowadays we eat a lot of processed food, so there's some lack of micronutrients that are important for all the physiological processes, as well as most of us are staying indoors, particularly now with the pandemic. So we lack of vitamin D. So perhaps maybe instead of going for vitamin D supplementation, which is very expensive, just go and stay in the sun
Stand in
for
the
5,
sun.
10 minutes in the morning or evening sun to get free
Okay.
vitamin D. Yeah.
Good. Okay. All right. We'll do that tomorrow. Okay. Okay. We've had one question that's quite interesting. Okay. What are the risks of the integrity of the embryos being compromised when they go through PGS, pre-implantation genetic testing?
Okay, let me answer that. Now, when PGT started, we started off with cleavage stage embryos, day 2, day 3, which have only probably about, let's say, a day 3 embryo, maybe 6 to 8 cells. Now, the risk of to make it more to reduce the error, so you take 1 or 2 cells out of the embryo. And by doing that, you may induce a trauma to the embryo. And because those cells that you have taken out, maybe destined to become babies rather than placenta. So now, sometimes, most of the time, when you grow them to blastocysts or you transfer them on day 3, the implantation and pregnancy outcome is lower than blastocysts. Now, when it comes to blastocysts, that means the embryo has gone through the day 3 and reached up to the final stage just before it implants. So they have hundreds of cells there. So when you take the biopsy from those cells that are going to give rise to placenta, so you probably take about 5 to 8 cells just to take it out. But then again, it all depends on the skill of the embryologist, how he or she obtain the biopsy, and how the embryo is frozen after that, while waiting for the results to come to arrive at 2 weeks later. Yeah. So that will overall we can compromise the if not done properly, will compromise the outcome of the survival of the embryo.
Okay, so it's possible at the end of the day. It's possible.
Just
now, just now, Dr. Liow, you mentioned that so currently, okay, a lot of people, they send their embryos overseas for testing, correct? Does Virtus have a center overseas that they can do testing? Because we know a lot of clinics who basically have a clinic in Malaysia where they send it over. Does Virtus have something like that?
In fact, Virtus Health is a large group. So we have a lot of sisters IVF centers in Australia. And we have Sydney, IVF Australia, Melbourne IVF. These are the 2 centers that can, they can send over there to do the biopsy and do the testing there. Yeah.
Okay.
But as I said, once you're there, you cannot the embryos cannot come back. But of course, with the current situation, because of the pandemic, so the doctors can appeal on behalf of the patient, but the MOH will review it on case by case basis.
Understand. Okay. Is it important to choose the right doctor? Okay, there's so many fertility doctors in Singapore. Okay, so is it important if you go to somewhere, you fail, Should I go to the next doctor, or should I continue? Or what's your thoughts?
Well,
Should I answer? Dr. Roland answer.
well, I always believe that I think for most patients that I seen, I always been telling them that you know you would like to, as much as possible, go through 2 cycles of stimulation and egg correction. With that, we have an opportunity of doing the first cycle, and then maybe the second cycle with some other modifications and optimizations. But I think overall, which doctors to see is really very individual, because
Yes.
if you look at the different doctors' approach to problems and all that can be very different, and sometimes these approaches suits you and it might not suit you at all. Now, some doctors are very much more straight to the point, but this could actually be interpreted as being blunt and insensitive.
Okay.
Whereby if you are less forward, and might be interpreted as being concealing and not telling
circle,
everything.
yeah, correct.
Yeah. So it is a really something that's very individual.
Okay. So in terms of, let's say somebody has gone somewhere and failed, let's say once or twice, do you think they should continue there, or should we ask for a second opinion?
Well, a fresh perspective on certain issues sometimes might be useful, but unfortunately, I always say one of the main concern about IVF success or not is really whether you had failures previously. So generally, if you had failed before, you know that the chances is already slightly lower. So certainly you can see whether different doctors can have a different perspective, but eventually the outcome might not be very different.
But may I add, just Kim, just for your information, we are at Virtus, we are seeing a lot of patients who have failed at least one IVF cycle elsewhere, even from overseas. And then when they come to Virtus, I'm happy to say that when they come for the first transfer, overall, they have about 70% chance of getting pregnant.
Wow, 70 is very high.
Yeah.
Okay, all right, fantastic. Okay, how does your center differ from a public hospital or other clinics? Very upfront question.
That's a very sensitive question and we answer very carefully. Well, I think we all know a few things. Number one, I think public hospitals are generally patient loads are much higher, so therefore they are usually busy, and usually they have to have different stations to collect your medicine, doing ultrasounds and all that. So some people might feel that is not the way to go, because we know that people who are doing IVF, first of all, I think most of them are all very busy, and they have lots of schedules to keep to. So I think that's where the private hospitals, private centers might be a bit more attractive to some people. But I think overall, we also said that in private care, we are talking about more personalized care. Yeah, not to take anything away from the public hospital, but it's really, with such a patient load and busy, little time to do so many things, it's just not so easy to deliver the same level of care.
Understand. So basically, private clinics give you a bit more personalization. Technically. Okay, also for Dr. Liow, how important is an embryologist?
Well, I think Dr. Roland will realize it, but okay. Now, let's break out this role here, because the doctor's role, the clinician role, is to assess the patient, what's the problem, and then after that go for the stimulation to get the eggs, and then collect the eggs, pass to the lab, and then the lab will have to look at the eggs and catch a good sperm, grow the embryos, and then after that the embryos will be transferred by the doctor and as well as together with the embryologist. After that, the doctor will look after that. So I think the lab contributes about at least 70% of the outcome for positive outcome for the patient. Yeah. I hope Dr. Roland agrees with me there.
Well, I have a different, slightly different viewpoint, but I totally agree with importance of a lab. But I think if you look at IVF cycles, treatment cycles, and with its success, that will be where we started Virtus, because when we first started Virtus, we said that we're going to emphasize on the 4 pillars of care. So in this case, it will be the IVF physician, the embryologist, the nurses, as well as our counselor. Now, not to take away any credits from any pillars or any party, and also not to award special credit to any parties. I think all 4 pillars are working closely together, at least in the Virtus Fertility, and we are very happy with the current outcome. And we feel that all 4 pillars are equally important.
Yes, we are going to like holistic approach to treatment of our patients. Yes.
I understand. So everybody is equally as important. I totally agree. Okay. In terms of your clinic, okay, just one more question about your clinic, okay? Birth rates. What are your live birth rates? I think this is a very important question that everyone wants to know. That's how they choose clinics. Basically, for ladies over 35 or 40, basically, what are your live birth rates?
Okay, currently, of course, the 2020 data hasn't been completed yet because some babies are still haven't been delivered yet. So what I can give you is the 2019 data.
Okay.
Now, because we do a lot of frozen embryo transfer, we rarely do very few fresh embryo transfer. That is because the advantage of frozen embryo transfer gives you a better outcome and better live birth rate. So for women who are above 35 and below 40, the live birth rate is about 48 to 50%.
48 to 50%.
As for women who are above 40, the live birth rate is about 26%.
Fair. Okay. All right. So that's basically quite good figures, especially for 48 to 50% for 35 years and above. Okay. Okay. One last question. Okay. Sorry. What's the improvement in implantation rate after doing an ERA test? Do you know? Okay, maybe you can explain what is an ERA test first before we say. Yeah.
Okay. ER is actually stands for endometrial receptivity.
Okay.
Okay. So there is this possibility of looking at which part of the cycle. Like, for example, we say that day 5 embryos should be transferred into a 5-day-old lining. But 5 days, you are talking about days, it breaks down to 24 hours. So therefore, we are trying to focus on where is the implantation window, whether it is beyond the 5 days, the 5th day, or coming to a 6th day. So there is a possibility that this influences the implantation rate.
Understand.
Now, there are a lot of markers that have been studied and have been biopsy and studies from the endometrial lining, and that is what is talking about to determine what is the endometrial receptivity. Right. So generally, this ER is actually being looked at when patients had supposedly repeated implantation failure. Now, implantation failure, can be due to multiple reasons. And here we still emphasize that a lot of the time when there is no implantation, it is still very likely, more likely than not, it is still the embryo factor. So of course, implantation factors, the endometrial factors is something that's very attractive. So there are lots of people who are looking at how thick should the lining be, how receptive should the lining be, whether there is any immunology aspect of the interactions before implantations. But I think Liow will also agree that the chances of that contributing to implantation failure is probably as little as just 10%.
Yeah.
Okay, so very little then.
So it still boils down to just optimizing the embryo quality.
The embryo.
And just by holding on to that point, I think we had our cases of a repeated failure, but we being persistent and carry on with how to improve the egg and the sperm quality to improve the embryo factor, we are still able to produce live birth.
Understand. Okay. All right. Great. We do have a lot more questions. However, time doesn't permit, okay? So what we will do is that we will actually get the questions to doctors. We'll try to get the answers, and then we'll share the answers out at a later date, okay? But thank you so much for your time, Dr. Chieng and Dr. Liow, okay? It's been very useful, and answering our questions definitely has provided a lot of information for our viewers. Okay, thank you so much, and we hope to see you soon again.
Thank you.
Thank you.
Thank you.
Thank you.
All the
Have a
best.
good evening.
All the
Good
Thank
night.
you very
Bye-bye.
much. Bye-bye. Thank you,
Bye-bye.
everybody.
Bye-bye.
Bye.